Thanks, everyone. This is the first time I've given seizures and transition together. So we're hitting on, I'm a neurologist, so logical that I could talk about seizures. And my career is an example of one of those situations where don't predict where you're going to be 20 years from now. I went into neurology, trained down at UCLA, where I was exposed. It exposes my age and where I trained. I trained in an era where the prevalence of autism was in the 1 in 2,500, 1 in 10,000. But at UCLA was one of the founders of behavioral analysis, or ABA therapy. Ivor Lovaas was a professor at UCLA. So we used to actually admit kids to the inpatient neuropsychiatric institute for ABA therapy. So I was exposed to autism in my residency. I thought everybody was, so I went into practice, and turned out I was one of the few people that welcomed people with autism in my practice, and next thing you know, I'm a so-called expert, which is a theme actually we'll come to, because I think becoming an expert in this field is really about working with people and families impacted by the condition. I guarantee you that most of my knowledge has been gained in the clinic, working with families and listening and kind of recognizing patterns and developing strategies that can be used. I wish it was more scientific than that. I wish we had we could put blood into a machine and come out with a spreadsheet on what to do, but we don't have that in autism. So it is a lot of kind of trial and error, and some families are comfortable with that, and some aren't. So I have no disclosures today. So we're going to hit a few slides on seizures and epilepsy. Notice we talked about GI, sleep, and seizures. These are the three conditions that have been proven to occur more commonly in people with autism, medical conditions. Dr. Kamenisch touched on the mental health conditions that are seen more commonly. So this is the third of the medical/neurological conditions. And then we're going to talk about trajectory into the adult years and kind of what to look like. Does anybody work with adults with autism? Yeah, so just one hand. So not a lot of you, but it's good for those of you that don't to kind of see what happens in adult. I think I guarantee you it's on parents' minds about what to expect. So it's kind of nice to have a little bit of understanding of that. So with seizures are common if you go out all the way into the adult years. Up to about 20 to 30% of people with autism will have had at least one seizure. The seizure types are all across the board. I think the big take-home message with seizures and epilepsy and autism is, if you see seizures, think possibly that this is a more diffuse problem in the brain. When we think about autism, we're really talking about the circuits, the neuronal network that's involved in social communication. People with autism that have seizures, they often have a more diffuse pathology. So these are the patients that more commonly are going to have intellectual disability as well. This is especially true if you're seeing seizures emerge at a young age. So if you look at this graph, this is a distribution of age of onset for seizures. So this would look similar to other epilepsies. So you see kind of a peak around the age of the emergence of adolescence, kind of in the 10 to 14-year-olds. But if you're in that early age, if you see seizures around age 2, that's a concern. That might be the type of kid that you refer to pediatric neurology or genetics clinic, depending upon where your practice is, versus a kid that maybe has a seizure at age 18. Then that is going to be a little bit easier to manage, more likely, and less likely is going to be a major burden. Whereas the kid that's presenting seizures at a young age, that's a real concern that could be a major burden to their care. The other point is, because of the wide variety of seizure types and the difficulty in getting EEGs often with this population, is that the medications that we will use will often be medications that have what we call a broad spectrum, so that they work for different seizure types. However, we will especially like to think about also how medications affect behavior. So a number of our seizure medications are used by the psychiatrists in bipolar disorder, and you'll see them as mood stabilizing medications, and you'll see them used in autism in attempts to kind of help with mood and behavior. And so if you have an individual that has seizures, you're going to say, okay, maybe I can hit two birds with one stone with this. If I have to put them on medication for seizures, let's pick one that maybe will help their mood and behaviors as well. Okay. This gets to the question, the point that I was saying before about a more diffuse pathology. So remember, when we think about autism and when we think about the diagnosis, there's nothing in the DSM-5 in our diagnosis of autism that claims to understand the underlying cause of autism. Now, that's what your parents want to know. They want to know what caused this. But in most cases, we don't know the cause of a child's autism. There are some cases, however, where we do know the cause. And these are cases you could use the term syndromic form of autism, in which the underlying cause is known, and autism is a symptom of the underlying cause. So the classic example that I think of actually is Down syndrome. Fragile X is kind of talked about as the most common genetic cause for autism. But I think about Down syndrome because it's an example of a condition that always autistic features were known to occur in some kids with Down syndrome, not all of them. And back in the day, back in DSM-3 and DSM-4, before we got to the kind of the current thinking of autism, if a developmental pediatrician diagnosed Down syndrome, they would not also diagnose autism in that child. Even if they had very prominent autistic behaviors and features. They would say Downs with autistic features. They don't have autism because they have Downs. With the newer versions, with DSM-4 and DSM-5, that changed. Okay, if you look and you say, oh no, autism is diagnosed by a pattern of behaviors in development. So you can have an underlying genetic syndrome and have autism at the same time. And that's really important. When you talk to parents of kids with Down syndrome, a kid with Downs without autism versus a kid with Downs with autism, those parents actually will identify, the ones that have autism will identify more with parents with autistic kids than they will with the other kids with Down syndrome. When we think of the classic kid with Down syndrome, they're friendly, they're very social, very engaging, versus a kid with Downs with autism is very different and requires a different approach, requires a different educational program than the kid with just Downs, maybe with intellectual disability, okay? So epilepsy might drive you to do a more detailed genetic evaluation or syndromic evaluation of a child if you see a new onset seizures in a child. This is just a slide just to show how much we've learned about the genetics behind autism. If you did full exome sequencing and full genetic sequencing of a person, which you're not going to do because insurance isn't going to cover it, you can discover a genetic abnormality in over 50% of people with autism now. So that's how often we identify it. A lot of these cases are what are called de novo mutations, and these are single point mutations in single genes that have been identified as risk factors. These are not, they're de novo, they're not inherited. So they're occurring in the egg or the sperm after the parent has become a person. And so they are not, the siblings are not going to be at risk for these conditions. Okay, and so this is something, when we get into the adult years, we're actually doing more genetic testing in a lot of people, because I will see adults and I'll see them as having dysmorphic features on their exam, or they've got intellectual disability and other things. And now they've got siblings that are worried about having kids because they're worried they might have a child with autism or this syndrome. And this is where genetic counseling can actually be very helpful and useful. I don't send everybody for this. This is where, again, I'm looking for these pictures of more of a syndrome where they've got these other conditions, they've got features on their exam, they're more severely affected. All right, so that's all I'm going to talk about epilepsy. I will say, actually, I did one point that I forgot to make, which maybe it wasn't even on the slide, so I have to go back and I have to tell you this because it was actually my question, and I realized, why didn't it get on my slide? So one of my questions was, there's one medication here that's not listed here that the neurology doctors love these days in treating epilepsy. And I saw somebody whisper it out there. So Keppra, or levetiracetam, is a real favorite medication. It's broad spectrum. It's got an intravenous route of administration so you can get its level up quickly. Very well tolerated. It doesn't require blood test monitoring. It's got like everything about it, except it aggravates behaviors in people, especially kids with autism. So not always. So we do have some people on Keppra and they do fine. So I think if you see somebody and they've just been started by their or the emergency room now, and they used to do Dilantin, now they're doing Keppra on this, and you see them come in, oh yeah, the ER started them on Keppra, and like, ooh, okay, let's just watch to make sure. Again, they might do fine, but just be aware of that can sometimes cause problems with behaviors. So I thought for sure I put that slide in, sorry. Okay. All right, so adult outcomes. So there was a question about, are we seeing the increase in prevalence everywhere? And the answer is yes, it is globally that this increased prevalence is occurring. The point of this slide is really just to highlight that this is a very common problem that we're dealing with in autism, and really we're seeing real struggles amongst our family practitioner colleagues at how to best manage this population as they become an adult. It seems like we're behind the times. We've made a lot of progress for early intervention and for kids, and we're definitely behind that, and hopefully we'll catch up with how we help serve adults. So the big thing that I get asked the question is, what's going to happen, to the kid as they get older? And just like it's a spectrum, of severity, the outcome is a spectrum as well. And this is a simplified analysis of the literature. Basically, think about 1 in 5 individuals. So this is if you take 100 kids diagnosed in their early years and you follow them out to age 18, you'll get about 1 out of 5 that will be defined as a so-called optimal outcome group. And this would be a group of individuals that if you put your blinders on to their early development and you're talking to them in real time, even testing them and putting them more detailed analysis, they really don't meet criteria anymore for autism, okay? And these are going to be the individuals that are going to go on and have jobs and have relationships, and maybe they're going to be programmers at Microsoft. They often will have still features of autism, and they might have higher incidence of anxiety and other mental health conditions, but you're really not going to recognize them, and you're going to wonder the question of like, wow, was this mistaken diagnosis? Maybe they never had autism. Did they get quote unquote cured of their autism? Did our treatments work? Was this their natural history? So these are questions that are really hard to analyze. But this is about the number. It's a nice number, 1 out of 5. I mean, I think it's encouraging. I think a parent automatically thinks their child is going to need lifelong support when a diagnosis is made, and this tells them no, that's not the case. Unfortunately, there's a similar number, about 1 out of 5, that do require lifelong support, kind of 24/7. These are individuals that, and we'll go over the kind of the factors that predict this, but these are the individuals that have more severely affected, often co-occurring intellectual disability and such. The majority are in the middle. You can still see their features of autism, but they're making progress, okay? And this is where I made this slide a number of years ago, and I find it still helpful for me. So what I've graphed here is kind of a developmental pattern, if you really think about social communication development in a typically developing human, is those individuals during their primary and secondary school years are really just making amazing progress in these areas, right? And then they get into the adult years and that progress kind of plateaus. If you look at people with developmental disabilities, and autism as a classic example of that, it's shifted. They make progress relative to themselves, but at a slower rate than their peers. So what does that do during the primary and secondary school years? If you're always comparing to your peers, you're actually falling further behind, even though you're making progress. That's really challenging, and that's a really important thing, I think, when you're counseling your families about what are you comparing to? Because often you'll get the parent that like, oh, they're having more trouble in school, et cetera, but yet when you really analyze their skills, no, they're chugging along and making progress. Now, the cool thing is for this population, I think, is in their 20s, they continue to chug along. And they continue to make this progress, and we can see them catch up to their peers in their 20s and 30s. Not completely, but we can see them make progress and gains. Now, the problem with this is that progress in the 20s, what's happened? Well, school goes away. Their opportunities to learn continue to go away. Their parents are burning out as their kind of primary case manager, so to speak. Their relationship with their parents and peers is changing because their peers are going off to college. So what we're seeing is a large percentage of individuals in this age, when they could be continuing to make progress, that are tanking, that are doing poorly. And we think that a lot of times this is these co-occurring mental health conditions that come on. But we can definitely see them stagnate because a lot of times it's this loss of services and loss of engagement in the community. So that's what we have to try to prevent from happening, that kind of poor transition into adulthood. So this is a slide that on the left side of this slide are factors that kind of predict this outcome or that are associated with these outcomes. And when I ask my residents to try to list it, they're pretty good. They could probably get this list on a multiple choice. Some of them aren't as obvious, but I think the big ones to note are that the one I have listed here of cognitive is actually probably a bigger predictor than the core deficits of autism in outcome. So if an individual has co-occurring intellectual disability, which it's hard sometimes to determine the intellect of a person with autism, especially if they have real significant communication deficits. I think about it as their problem solving, a little kid that isn't talking but knows to go get the chair to put so he can go steal my toy that I put up at a high shelf so he couldn't get. That's a pretty good problem-solving ability to do that. You'll get the individual doing, and we typically assess this through adaptive and functional skills. An individual that's learned how to use the bathroom, learned how to follow instructions and things like that. Those are pretty good signs of some degrees of intelligence. And obviously, individuals that are verbal, you can test intelligence pretty well. The co-occurring deficits, the core deficits really break down to me the way that where we used to, in DSM-4, we used to break out communication and social. And so I think about that actually, an individual can be minimally verbal, yet very social. You can have an individual that is very talkative, has intact language, but has no real desire to talk to you. And you can have an individual that's communicative, social, but only wants to talk about Star Wars. And so you can kind of see how each one of those three is an independent variable, and the research has held that out, that those are all kind of individual predictors. The co-occurring conditions are big, and this is where I think the primary care world can really get involved in managing the GI, managing the sleep. These are very important issues, and then the mental health is just huge with so many. Some individuals, the co-occurring mental health condition is the primary barrier, depression or anxiety, or if you get into even a more severe mental health condition. Adaptive skills is something that is another area that you can focus on as a primary care physician, is to remind the parents the importance of developing these life skills and adaptive skills. The school often doesn't have time to do this. Okay, the school is working on reading, writing, arithmetic, and those basics especially. It's often not until later an individual that's maybe not doing as well where they're like, okay, we're going to shift to life skills as their program. So parents need to be doing this at home. And you can only fight so many battles, right? Not tying the shoelace, not going to pick up the clothes, and having the child do that, it's just so important. And these are the types of things that you have to do 1,000 times before them to get fluent in these skills. So that's really, I would encourage kind of coaching on that as really important. Your classic situation, the kid that's super high IQ with autism, parents are seeing him, become the next Einstein, goes off to college and fails because he can't do the basic adaptive skills to survive in the college setting. Okay. Extrinsic factors are the ones that, unfortunately, the accessing services and family community support are, it's good and bad. In some ways, I wish that those weren't such a big predictor of outcome. But on the good side is those are things that we can do something about, is making sure that the families have access to services that are available and that the parents are staying engaged because really, as much as we'd like to help, the parents remain the primary case manager, so to speak. And all of these things on the right, I think the main thing I want to point out here is that this is the same list that regardless of age, except for maybe the work training part would be the one that's for adults. Unfortunately, every one of these things is less accessible in the adult population. The classic example is applied behavioral analysis, which for your Medicaid families is medically necessary up to age 21. When the class action lawsuit was several years ago that designated ABA as medically necessary, the judge ruled it up to just age 21. So our adults on Medicaid cannot get access to ABA therapy. And that's unfortunate. Hopefully, Washington Autism Alliance and Advocacy will be filing their next suit shortly. I think there's a big, this concept that kind of school goes away and there's not as many opportunities to learn. The places where individuals can continue to learn, such as in a job or going to college, our success rates aren't very good right now. So we've got a lot of room for improvement in the United States as well as in other countries. And we're seeing a lot of progress. I think we're seeing a lot of colleges developing specialized programs for people with autism. I think we're seeing a lot of efforts by employers, large employers, and we're lucky to have Microsoft and Amazon here in our community. They've been really spearheading a lot of the work that's been done on the employer side. Housing, we're seeing a lot of new opportunities that are going to be developed and entering our community. Right now, things are dismal in all of these, but I'm hopeful that we're going to see progress over the coming decade. And I think that the point of this slide is, as medical providers, we're focused down here, but to think that these things aren't connected is foolish of us. I think we have to remember that if a person is homeless, or if a person is unemployed, or if a person failed out of college, how that's going to affect their mental health and physical health. So we need to be prepared to have these conversations and engage with our families around these other topics that quite frankly, we're not trained in our medical residency to learn about these things. So this is a lot of responsibility for us to kind of to become acquainted with these issues. And if you're going to work with this population as adults, you do have to kind of do some self-education around this. The transition planning has been a big focus, not just in autism, but so many other conditions now that transition to adulthood, a lot of pediatric conditions surviving into the adult years. This has become an area that's clearly identified that pediatricians will often hang on to the individuals and maybe never give them up or don't know who to hand them off to. Certainly the adult providers are not waving their hands, hey, I'll take them on. So this is really hard on the medical side to know who does this. And I put this slide up just to show an example of what a poor job we're doing right now in the area of kind of transition. So this is actually was a study done by Emily Myers, who's one of our developmental pediatricians at UW and Seattle Children's. And she looked at this study that was a national phone survey of parents taking care of kids with special health care needs. So it wasn't just autism, it was very broad, but she focused on just the families that had autism. And they actually did this group, it was a cohort that was followed prospectively from their adolescent years into their young adult years. And the researchers would call these families at 5 different occasions across this kind of 10-year time period. And she specifically looked at the group of autism and specifically looked at questions related to social participation and community participation. And what she found was that individuals at wave 1 in their early adolescent years, they were participating in the community and participating socially at a rate that wasn't that great. And just to give you an example, like specific questions would say, has your child been involved in a community event over the past year? So if you answered yes to even one event, you're in this part of the bar, which tells me that 36% of people had 0 events in community participation at that time. It's pretty low. But look what happens by the time they're a young adult. That has gone down, so now you've got over 50% of people that are having 0 participation in their community. Okay, that is a really concerning number. How do you expect to continue to learn? How do you expect to continue to make progress socially if you're not having opportunities to engage in the community? Socially, it stayed more stable, which is interesting. The way we have analyzed that, we don't have proof of this, is that social engagement is more kind of an intrinsic skill, whereas community participation requires the help of the family and the help of the community. So it's more of an extrinsic factor. The factors that influence these numbers, household income did influence it some, but this concept of having a case manager, and it wasn't defined in the study what a case manager was. We are assuming it's the parent, quite frankly. At least in Washington State, that's how probably people would have answered that. So it really, unfortunately, puts a lot of burden on these families, right? Because our society is not stepping up like we need to see it. We're not providing the job opportunities yet. We're not providing the post-secondary education opportunities yet. And just general participation in the community, such as things like Parks and Recreation and other organizations. The cool thing is we're seeing interest and we're seeing progress. Examples here like the Pacific Science Center and the zoo, and Seattle Theater Group, had its first sensory-friendly performance of The Lion King this year. Did anybody get to go to that? I mean, one of the best events I've ever been to in my life. So, and they're going to have Frozen next spring, so keep an eye out for that. These are examples of our community needing to step up. And if you think about it, providing accommodations, if you want to think about it that way, but really welcoming everybody into the community. And this is really what we have to do. On the provider and physician side, we need to train more providers, and I will. On that, since I'm getting the 1-minute sign, I am going to just highlight a couple other things. Studies that show this community participation makes a difference. Studies that have shown that having a job actually further improves the symptoms of autism. That having a job almost becomes the therapy, right? So this participation is just critical. The issues about how to get a job, we could spend an entire time about that, the important aspects about what's important, not just to finding the right job, but then keeping the right job. Trying to really focus on the skills of the individual, not just the deficits. And I'll end with this busy slide. This is just an invitation. So has anyone heard of the ECHO training model? So ECHO training model is a method where so-called experts meet via teleconference with community providers to help community providers become experts. They can present cases. Their actual cases can get presented in a de-identified manner, and we review the cases and we give recommendations. And ECHO Autism was first launched out of University of Missouri a number of years ago around early identification and diagnosis. And we just piloted ECHO Autism for transition this last fall. And colleagues from University of Vanderbilt just got funding from the DoD to continue this. So anybody interested in participating in ECHO Autism transition, so these would be pediatric providers or adult providers that care for this kind of age group would potentially be invited to participate in that. So feel free to contact me if you have any interest in that kind of going forward. And we have seen pretty amazing evidence anecdotally about the importance of this kind of community engagement. We have a program up in Bothell called the Alyssa Burnett Adult Life Center. Has anyone heard of the Alyssa Burnett Adult Life Center? So this is a program for people 18 and over, autism and other conditions. It doesn't have to be autism. We run the program it's a hybrid between a Parks and Rec and a school. We're 5 minutes from Bothell, so UW Bothell campus, so students from UW Bothell come and embed in these classes as typical peers. And we do everything from cooking to music to Zumba to Disney movie appreciation class. It's really the participants kind of drive what the class content is. We'll have a content expert that teaches the class, but then we have a behavioral person that's one of our staff kind of embedded in the class as well. It's very intentional around learning, social skills, life skills, recreation and vocational skills. And we've seen examples of individuals that have become stagnant. I'll end with the story. Our oldest participant, who's in his 60s, started coming. His caregivers would drop him off. Hey, he doesn't talk. He's nonverbal. Well, he's been participating for about the second or third quarter. He started saying hi. He started playing interactive games. He's now, his verbal use is still minimal, but he's using words in communication with our staff. So it's never too late. You can teach old dogs new tricks. It's just a little harder. It takes a little more work. And I think that's really the take-home message for everyone, and for teaching families that this is a long haul. It's going to be a different trajectory than what you expected when you first were considering having children. But it's extremely rewarding, to see this ongoing progress. And when you reach that state where the parents are fully not just accepting, but celebrating and embracing their child and their differences as well as their strengths, then I think you've really reached your goal. So I'll end with that. We've got, I think, a few minutes for questions, and then we'll go off for lunch. I'm sure everybody's hungry by now and wants to get outside. So, but any questions about what we talked about or other topics this morning? Yes.
Is DBT available to folks with autism in this area? I know in other settings DBT is, and can you discuss the difference between CBT, cognitive behavioral therapy, and dialectical behavioral therapy?
Probably you can discuss the differences better than that, TK. But I think the question about the one slide that I had up there that said basically all the treatments are available for adults, but they're all less. And I think and it's very similar to what we heard about the sleep. When you look at the literature, there's very fewer studies that are specific to the autism population, but we're starting to see those evolve. And so we're starting to also see providers in the community where you're starting to have a few more here and there that I would say at least welcome people with autism into their practices, and then a few of them that kind of focus on that. In the past, we've had like at our community mental health clinics where if they have an autism diagnosis, we will not treat them. And it's really frustrating for us. It's like saying if a person has multiple sclerosis, they can't get treated for depression. It's not quite the same, but it is somewhat the same in that people with autism have a higher risk for depression and anxiety. So I think what it gets into is the cognitive ability of the individual, about the strategy. So I think you're going to need to get into cognitive behavioral therapy or DBT, you're going to have more participation from the individual. The more participation you need to have effective therapy, then I think looking at that cognitive ability becomes critical, as well as I would say not just cognitive ability, but motivation to participate. Motivation is such an important issue in autism. What is motivating the individual, right? People with autism, they have difficulty seeing things from other people's perspective. That includes seeing things from their own person at a future point in time, right? If you think about it, they have troubles planning into the future. The classic thing, you ask this 130 IQ kid in high school, what are you going to, you think about what are you going to do as a grown-up? I don't think about that. It's like, I'm focused right here, right now. I'm really good at that, but I'm not good at kind of seeing that future. So that's challenging then, I think, with the types of therapy, and I think the more cognitive difficulties or the more difficulties you have with motivation, the harder it's going to be to apply some of those treatments, and probably the more autism specialization you need from your therapist. So that's when I would be leaning more towards ABA providers, if we're seeing problems in motivation or cognitive ability. Is that a fair? I saw a few little, right, yeah.
I would just say that there's some parallels to medication management. I mean, you're really trying to borrow tools and apply them in an appropriate manner. So ABA, CBT, and DBT all have B, and I emphasize the B. It's going to be more of a behavioral approach, and you might borrow some strategies or ideas from dialectical behavioral therapy or cognitive behavioral therapy, depending on the target, the cognitive abilities, but it's just flexibility. And so when I'm trying to steer parents towards individual support, if it's not strict ABA, I'm suggesting they find someone with experience working with children with autism who's flexible, who might borrow from motivational interviewing strategies, who might borrow from, just thinking about flexibility more than and comfort with autism than are they going to rigidly apply DBT and could this work for this kid? It's hard to say.
Yeah, a number of our psychologists are working on mindfulness strategies and mindfulness therapy in autism now. We're starting to see some early evidence that that's got a lot of success. And I've had some really cool anecdotal stories in my adult practice of the benefits of routine kind of mindfulness practice on a regular routine basis having a real positive effect. So that's something to think about. I think another thing that we underestimate the barrier that sensory sensitivities creates for this population, especially as they get in the adult years. It's turned out to be one of the primary barriers for employment has been the sensory sensitivities. So I was really happy when DSM-5 kind of added that. And I think that we've become more in tune to kind of recognize that sleep is a classic example of really needing to query the sensory sensitivities. That's where you see some kids that benefit from a weighted blanket, which is another thing a primary care could consider. And I think asking those questions about the sensory, is important for that, and might get into other types of then sensory-based therapy. When you think about so much of what we're going to be doing with these kids is trying to desensitize them, and so whether it's a food, whether it's a, not wanting to hear the loud flush of the toilet at Starbucks, and so then they become phobic of going to the bathroom, whether they had some sort of traumatic event in a employment setting and now they're having trouble going back to work. So everything, a lot of times about thinking about desensitizing. And I've used actually my work, having worked a lot in traumatic brain injury and thinking about the return to work or return to play protocol in sports concussion. So with return to play in sports concussion, what they've learned is there's a sweet spot. If you push too hard, you worsen the symptoms. If you don't do anything, you don't make as good a progress. So they shoot for like 70%, this maximal rate. And I think that's a really good analogy for thinking about both desensitizing as well as trying to make gains. I think a lot of times parents will push too hard in a certain area, and it causes this kind of reaction from the kid that makes it then really hard. You want to have successful outcomes, right? You want to be gradually making progress and having, success along the way. That's one of the reasons the ABA therapists are so good, because they measure, right? And they go based on developmental level, and they kind of, when they're doing skill acquisition, and they're rewarding for the progress. One comment that I get from adults, that mistakes that we make in our pediatric practices, not focusing enough on the positive. We tend to just focus on the negative with the kids and with their parents, and not teaching self-advocacy skills early. So that almost gets to those kind of functional deficits, but in addition to that, being able to advocate for themselves. So sorry I went extra on your question. Yes?
There's such a wide range of ability under this diagnosis of ASD. And I'm curious why the diagnosis of Asperger's was eliminated for the high-level population.
So it's a great question. So if you look back at DSM-4 had, it was pervasive developmental disorder, and they had 3 subcategories. So they had autistic disorder, Asperger's disorder, and pervasive developmental disorder not otherwise specified. Asperger's, if you look at it, was somebody that had a normal language onset, so they spoke. Often it was the little professor that even spoke early, and they do not have intellectual disability. So that was the difference, okay? When they looked at those individuals like age 12 and age 14, and you put your blinders on, you couldn't tell the difference between the 3 groups. And when you looked at